Hello, thank you so much for joining us for this conversation. And I would like to introduce Dr. Kater to you, who is in Amsterdam, a hematologist in Amsterdam. And Dr. Kater, would you like to introduce yourself?
Yeah, thank you very much, Alex. So I'm Arnon Kater. I'm a hematologist here in Amsterdam. And I'm also the chairman of the Dutch CLL study group, part of the HOVON. And I'm also in the executive board of the ERIC. So I do indeed a lot of translational, but also clinical studies on CLL.
Thank you so much. So today we will talk about the clonal minimal residual disease dynamics on Murano study. This is what you presented at ASH. So could you briefly outline for us what this study has found?
Yeah, so the Murano study was the first study actually, which now quite old already, like 4 or 5 years. But where a fixed duration non-chemotherapy containing regimen was used, which was Venetoclax Rituximab versus Bendamustine Rituximab for the relapsed patients group. And the study itself showed both increased better outcome if you look to the progression-free survival, so time till disease came back, but also improved overall survival. And since there are so much data on this study, you can actually do a lot of interesting calculations. And one of the things that we use is the minimal residual disease, which is, so I think most people have heard of it, but minimal residual disease means that below detection level, what was before that, we can now pretty sensitivity measure whether or not there are still disease cells around normal cells. And the level of detection that we could do now, even people say even 10 to the minus 6, but in this study is 10 to the minus 4 to 5, which means that we can measure one leukemia cell up on 10 or 100,000 normal cells. And if you do that over time, you can actually not only say how deep the remission is, but you can also calculate, since you have a lot of samples after treatment was stopped, how long does it take till the clone comes back, till the disease comes back. And that's kind of a mystery. We know that people can stay with CLL for years kind of stable, but after treatment, we don't know so well how quick the clone grows back and what the dynamics are. And to cut a story short, what we found in this study is that if you compare the growth rate, so the speed that the tumor comes back after stopping of treatment was actually slower after Venetoclax Rituximab than after Bendamustine Rituximab, showing that it's not only disease specific, but also treatment specific, how quick the treatment, how quick the disease comes back. We also looked at other markers, such as mutation status or P53 status. And there we did not really find this difference. So it was really the therapy itself. It was kind of a very good predictor of how fast the disease comes back, showing that different therapies change the dynamics of the disease.
Okay, so thank you so much. So basically what I'm hearing is that now you can predict disease recurrence by measuring this MRD dynamics. Is that correct? And how do you foresee that might be used in the clinic?
Yeah, well, I think that's correct. So just to give the numbers that we found. So every time the MRD doubles, then you can call that we call the doubling time. And that was in our study for Bendamustine Rituximab for all groups, for all patients, it was a median of 53 days, where it was almost 100 days for Venetoclax Rituximab. So that's kind of the difference. Well, if it really matters to patients in the current state, I am not sure yet. I think we are also in the HOVON and together with the Nordic group and the Germans are thinking of trials where you not only treat when patients have symptoms and are ill, but maybe with these predictions, you can actually start thinking whether you should treat patients where we know there is a very strong rise of the disease and that you may actually prevent problems. Whether you should do that or not, that really has to be in trials. You should really not do that outside trials because we don't know if there is a real benefit or not. But it kind of helps that you can do much better disease controlling with this kind of things. And for sure, that's interesting for the biology. Alex, if you ask me now about your opinion, I think for now, it's very difficult to predict whether it really has immediate clinical implications. I actually don't think so. Do you think so?
Well, I think maybe sometimes, I think, if there are patients who, develop rare CLL complications, like, for example, autoimmune cytopenias, I have some patients who actually I treat the disease, and then the first thing which comes back is hemolytic anemia, and it comes back before I can even detect CLL by lymphadenopathy or a high lymphocyte count. So I think for these patients, it might actually be a tool to determine when there is disease recurrence. But I agree with you. For most patients, maybe we don't quite know how to use that tool yet.
Yeah.
And your clinical trials will be important.
Yeah.
Okay. And of course, the other point is that once again, Venetoclax rituximab appears to be much more effective in patients with relapsed CLL than Bendamustine rituximab. Do you still use chemoimmunotherapy in your patients?
Immunotherapy. Yeah, actually, we start out. So we have now different trials. We have a trial with the LAVA study that we'll discuss in a minute. And we also have here open the phase 1 study with epcoritamab, the CD3, CD20 antibody.
But I mean, chemoimmunotherapy. So chemotherapy, do you still use it in treatment of CLL?
Oh, so let's start again then. Okay, 5. Can you ask a question again? And we can cut it out.
And of course, another point of the study that we just discussed is that Venetoclax and rituximab is much more effective than Bendamustine and rituximab in patients with relapsed refractory CLL. So, Dr. Kater, do you still use chemotherapy in treatment of CLL?
Yeah, so in the relapse setting, it's I think specifically because the Murano study, it's not preferred anymore. Although you have to say 2 things. One is that in the Murano study, all patients have had chemo at earlier lines of treatment. So we don't actually know anything about patients that did not have chemo, but ibrutinib, for instance, as first-line treatment. And the second thing is that there are some compelling data, specifically from the German study group, that if patients were in a remission really for a long time, more than 5 years after chemoimmunotherapy, those patients you can actually consider again giving chemoimmunotherapy because it will again probably prolong for a long time, as long as they don't have a p53 deletion problem. In first line, there's a big debate in Holland because as long as we don't know that you have really overall survival advantage by starting with one of the novel agents, you can still make the case that at one point, since we cannot cure the disease now, at one point you will get those targeted agents anyway. But if you completely throw away your chemotherapy, you miss maybe a very effective line of treatments. So at least for the patients with unmutated IGVH, where we know there's much less of an advantage with the mutated ones for chemoimmunotherapy, there is still, I think, a role for chemotherapy.
Okay, well,
yeah.
Thank you very much for this answer. Thank you very much for talking to us about this important work. All right.